Welcome to today's podcast on motivational interviewing in healthcare settings. My name is Jay Suhan. I'm a clinical professor in the departments of psychiatry and family medicine at UC Irvine. In today's podcast, I'm going to be going through a practical overview of motivational interviewing. And the objectives, as you can see, are first of all, reviewing the spirit and principles of motivational interviewing, or MI. And then I'm going to utilize the four processes within MI to illustrate the flow of MI. And then finally, I'm going to be demonstrating some key MI skills that are used to assist patients towards health behavior change. The content in this podcast is really drawn very much from two books that you could see here on motivational interviewing, one from Milner and Roenick, and the other from Berger and Valum. I also want to give a special thanks to Dr. Lawrence Brown at Chapman University, who helped prepare some of the materials for this podcast. So let's start with just asking, what is MI? There are a number of different definitions, but I like this very brief one. It is a patient-centered counseling style for addressing the common problem of ambivalence about change. So ambivalence, of course, is having arguments for and against doing something and having that at the same time. And this is actually a very common experience that everyone has. This type of counseling style actually began in the field of addiction, where it really helped patients really think about their ambivalence about using and not using substances. But then it really expanded to the rest of healthcare, and really in particular to the chronic illnesses and lifestyle changes that many of our struggles and frankly we ourselves struggle with. The spirit of motivational interviewing is one of partnership, which basically means that we're collaborating with our patients rather than dictating. It's also one of acceptance and really recognizing that patients really make the final decisions about their own healthcare, and that we need to accept that autonomy. Compassion, which is that everything that we do is really in the best interest of the patient, and that we're not doing anything that the patient does not want to do. And finally, of evocation, and this is really the idea that the best ideas come from the patient, not us as providers. So in this podcast, I'm going to be focusing really on the chronic health conditions and lifestyle changes that medical professionals really deal with day-to-day basis. So how does MI differ from the traditional principles of patient care? Well, you could see here that the traditional principles are really based on essentially being the backseat driver for our patients. That we oftentimes find ourselves giving a lot of information, lots of advice, and if we meet resistance, we usually meet that with more advice. And our goal in this approach is compliance. In fact, we talk about how patients are non-compliant with what we ask of them. And this really comes from a place of feeling like we know what's important for the patients rather than our patients. Now, there are certain situations in medicine. So, for example, emergency room settings and a very emergent medical decision making that needs to be done, or in patients who basically come in and really want to know what our opinion about something, and they're ready to hear that information, then really the traditional principles are pretty reasonable. However, in most situations in medicine where it's not an emergency, or if the patient is ambivalent about whether to or not start a medication or start a treatment, then we really need to think of working with our patients more like as you can see here, more like a GPS, where we assist the patients to where they want to go, and we offer choices, and we remain curious about what their lives are like and what it really influences their decision making, and then we can best serve them. And if we meet resistance, we roll with it. We don't try to argue our way through a decision. We allow the patient to have self-efficacy, because our understanding is the patient wants what's best for themselves. It's a matter of how can we help them to get to that point. And the end result with motivational interviewing is that the patient argues for health behavior change, not the provider. So how do we do MI? Well, you could see here there's what we call these four processes, or sometimes also called the phases of motivational interviewing. And it begins with the process of engaging. And during this process of engaging, we will identify an unhealthy behavior. And that might come from chart review, or it may come from the initial conversations with our patient. And the goal here is to really understand where that behavior is coming from and to build rapport. And as that process continues, we actually decide, we come to an understanding of what's perpetuating that unhealthy behavior, and that's the focusing phase of MI. And then once we have that, then we begin the work of evoking the patient's own motivation for change. And we'll talk about different reasons why a patient may be doing an unhealthy behavior and what things that we can do to help the patient overcome that. It's only after we've done these three processes that we finally go to planning. And this is where we actually work with the patient about what they are able to do as a health behavior change. Now, even though I've shown these four processes in a certain order, and certainly you want to do the process before moving on, they do overlap to a certain extent. And in addition, you may find that for some patients, an unhealthy behavior, you would be able to go from engaging to planning within a single visit. Or for patients who have more ambivalence about a particular health behavior, it may take multiple visits in order to move through these processes. So what I like to do now is to go through each of the different processes and describe the skills that could be very useful when collaborating with your patients. So the first process of engaging, we're really trying to understand the patient's perspective and situation. And we do that by trying to get the patient's sense making of their problem. So this is how a patient makes sense of an illness or treatment based on their previous knowledge or experience with it. And this is important because that sense making leads to the health behavior. So that's one very important goal of the engaging process. The second is building rapport. And of course, there's two parts to building rapport. There's the nonverbal, which are things like good eye contact, shaking their hand, mirroring them in their affect. And then there's the verbal parts of rapport building. And that's what we're going to focus on with this podcast on motivational interviewing. So let's go to the skills in the engaging process. So we are trying to, again, build rapport, and we're going to be trying to explore the patient's sense making. And we're going to be using these skills called the POARS skills. The P in POARS stands for asking permission. So that means that when we start to engage a patient about a health behavior, we're going to first ask permission to do so. So as an example, is it okay, or can we talk about your diabetes, or can we talk about your high blood pressure? Can I give you some information about your high blood pressure? This is, we ask permission because it's a collaborative thing to do, and it shows respect, and really sets the tone that this is not going to be some kind of interrogation. The second letter in POARS is the open-ended question. These open-ended questions begin with how, what, where, why, and they end with the question of how does a patient feel about their health condition? What do they know about, for example, diabetes, about high blood pressure? How are they dealing with their diabetes? What do they expect from the medication? What do they expect from the illness? And if the patient has had a previous experience with, say, for example, weight loss, you might ask about their previous experience. What we're essentially doing here is exploring the patient's sense making, and that's what I'm trying to illustrate with the picture. This rower is not going in any particular direction. He's exploring, and that's what we're really trying to do during this engaging process of MI, is really exploring the patient's sense making. Now, when we move on to, if we move on to the A, R, and S, A stands for affirm. These are positive comments on the patient's strength, effort, or intent, and really these affirmations follow the open-ended questions. So if the patient is talking about trying to start to walk or run, we might provide an affirming statement such as you're very interested in your health. If the patient has only walked twice this week because lots of things were going on in his or her life, then we might comment that you walked twice this week despite those things. Uh, R stands for reflect, and this is, in its simplest form, really a restating of what the patient says. And we do so without advising, without judging, or correcting. So if the patient is telling you how overwhelmed or frustrated they've been because of things that have been going on there in life, you might just simply reflect back that you're feeling overwhelmed with those things that are going on. Sometimes it could feel almost too simplistic, but really what we're trying to do is to really let the patient know that we are paying attention, and we recognize the emotions that they're bringing into their experiences. S is for summarize, and this is a collection of reflections that we've made during that process of engaging with the patient, and it allows us to really sum up the thoughts that the patient is having, and really all three of these are very effective ways to build rapport with our patient. Now, how might that look like in an actual conversation? So we might say, can we take a few minutes to talk about your blood pressure? Patient answers, sure. I've noticed your blood pressure has been high in the last 2 visits. What are your thoughts about that? Well, I know high blood pressure can cause heart attacks, but I've been feeling fine, so I guess it doesn't bother me too much. If it was causing you symptoms, you'd be more worried about it. That's right. So then how often do you take the lisinopril? I'd say about 2 or 3 times a week because things are just really kind of hectic right now. So despite being really busy, you still try to take the medication when you can. Yeah, I take it when I can. So here, a summary statement could be, on the one hand, you know that high blood pressure can lead to heart attacks, and on the other hand, you've been feeling fine, and life has been hectic, so it's not been a priority to take your medications every day. Now, if we were correct, the patient would let us know. They would say, yeah, that pretty much sums it up. So when we move on to the focusing process of MI, you could see here that what we're going to do is to assess the patient's sense making. So if we were to break down that summary statement, we could see that what the patient is essentially saying is, I feel fine, so high blood pressure isn't a big deal right now. Plus, my life is hectic, and that leads to or equals medication not being taken regularly. So what we see are 2 different statements that actually leads to the result. The first is what we call a factual premise, and that is a medical belief that can be addressed by medical expertise. The patient feels fine, so doesn't think the high blood pressure is a big deal, and we can address that with information. And if we're able to do that effectively, we can essentially increase this patient's perception of importance for change, in this case, taking the medication more regularly. But you could see the second part of the statement is a motivational premise. And this is quite different from a factual premise because this really speaks to the patient's desire, ability, reason, or need for change. And that has to be elicited from the patient. It's not something that we know. This is information that the patient knows, and we need to draw that out from the patient. And if we can do this effectively, then we may be able to increase both the importance and or the confidence for making that change. Now, when we work with our patients, not everyone is going to have a factual premise. Not everyone's going to have a motivational premise. They may just be one of those 2. The important thing to recognize here is that if the patient has both, then both of them need to be addressed for the patient to take the medication more regularly, or to at least lead to the positive behavior change. So we're going to now dive into how do we address a factual premise. So you could see here, I feel fine, so high blood pressure isn't a big deal right now. It would be very tempting to reply to the patient with something like, well, you have to understand that you're actually not doing fine. High blood pressure is, and fill in the blank. Now, the problem with this statement is this is not the patient's lived experience. The patient just told you, I'm doing fine. So that is not something that the patient is going to agree with. If you said, you have to understand that just because you're feeling fine, it doesn't mean that you're doing okay, because this is dismissing the patient's sense making. If you said that you have to realize your high blood pressure can cause heart attacks or strokes, that doesn't work because the patient already knows this. He's already stated this. So responses like this actually have the end result of the patient losing face, meaning now the patient feels like you're talking down to them. And we also end up losing rapport. And so really anything that we do past this is going to be really handicapped by this loss of rapport. So what does this mean? It means that new or missing information that we want to provide to the patient has to fulfill some criteria. It has to directly address and add to the patient's sense making. So if we think about the patient's sense making as a lock, as you can see here, then the medical information that we're trying to provide is the key. And that key has to fit into the patient's sense making lock. Correcting the patient is not going to be helpful because, again, it loses rapport. So we have to really fit into the conceptual world of the patient. So we can do that by, and we can be assisted in that, I should say, by using simple analogies, avoiding jargon, and then finally, it has to be presented in a neutral form. So if you think back to those examples I mentioned earlier, I began those statements with things like, you have to understand that or realize that. I've really already handicapped myself there because I'm talking down to the patient. So presenting it more neutrally is oftentimes going to be much more effective. So what is an example of a more neutral statement? High blood pressure causes no symptoms early on, and this has been your experience. Over time, that constant pressure weakens the blood vessels. And at some point, the weakened blood vessels can leak or burst, and a person feels it as a heart attack or a stroke. We can alternatively do the same thing with an analogy. If you think of blood vessels like a garden hose and high blood pressure like leaving the water on full blast all the time, the garden hose will weaken over time and more likely to leak or burst, and a patient would experience that or feel that as a heart attack or stroke. So you could see here, I'm not questioning what the patient has said. I'm simply adding to that patient's sense making. I'm avoiding the use of jargon or complicated medical phrasing, and I'm presenting this very neutrally. So now that I know how I might want to address it, what information I would do to address it, let's take a look here at how we would do that in practice. So there is a tool called the Ask, Provide, Ask tool. And that basically means that you ask open-ended questions to clarify the sense making, and we've done that already during our engaging process. You then reflect that sense making back to the patient without judgment. And again, in my summary, I've done that. That's an example of that, I should say. And then we ask permission to share new information that may be relevant to their reasoning. We then provide that missing information. And then we follow that up by asking them about what they thought about what we just provided. We allow them to respond, and then depending on what they say, we're going to go ahead and reflect back and summarize. So I want to go through an example of this. And of course, if we are able to do these steps, we both directly address the issue, plus we maintain rapport. And you really need both of these things to be effective. So let's take a look at an example of hypertension. So the patient, we've asked open-ended questions, and the patient tells us that I take medications a few times a week because honestly, I feel fine. Provider says, you're wondering why you need to take a medication if you're feeling fine. Patient says, yes. We respond, that's a great question. Would you mind if I shared some information with you and you let me know what you think? Sure. So high blood pressure doesn't cause symptoms early on, and that's been your own experience. Over time, though, the constant pressure weakens the blood vessels, and at some point, the weakened blood vessels can burst or leak, and a person feels it as a heart attack or stroke. What are your thoughts about what I've just described? Wow, no one's really explained it to me that way before. I guess it makes more sense now why I would want to take that medication every day. Well, you just wanted to make sure that it was something that you needed. Where would you like to, or how would you like to proceed from here? So in this particular example, what we've done is we've reframed the patient's skepticism about needing to take the medication every day as a question. And this idea of reframing allows us to have the patient consider their health behavior in a different way, from a different lens. And hopefully, if we've done that effectively, allows them to reconsider how they're thinking about it. So in this example, we reframed it as a question, as you're wondering why. And of course, if we do that, it sort of begs an answer. And so reframing it as a question sort of automatically sets us up to provide the information. Now, other times, the patient may cite not a skepticism about a treatment, but a barrier to the treatment. So, for example, a patient might say, if the medication didn't, I'm sorry, the medication is causing dry mouth, or the medication is too expensive. We might reframe it as a conditional commitment. If the medication didn't cause you dry mouth, you would consider taking it. Or if the medication wasn't so expensive, you would consider taking it. So if the patient says yes, then you've already got a commitment to retry something else. Or at least help them at that point, help them potentially with a lower cost alternative. Other patients might respond by saying, you know what, I just don't know if this applies to me. So they might say, for example, that both their parents have high blood pressure and they've never had a heart attack or stroke. You might reframe that as an insurance policy. So you might say, God, your parents have not had any problems as a result of heart attacks, although, as you know, the other patients have. And you might consider taking a medication every day as an insurance against having something like that happen. Finally, some patients are just not ready for change, and regardless of what you say, they may just not signal readiness. In that case, sometimes it's helpful to reframe it as a look over the fence. So, for example, what could happen if you didn't take the medication? If we've done our job effectively, or if we've been able to reframe effectively, I should say, we may be able to work with our patients to then work on the planning process. However, let's look back at our example that we used earlier. We finished, or we stopped at when we said you wanted to make sure that it was something that you needed. How did you want to proceed from here? The patient may respond, well, I want to take it every day, but my job has unpredictable hours, and when I get home, my partner needs help with the kids. What we see here is that we've been successful in addressing that factual premise, and so the importance for change has increased, and in fact, the patient expresses a desire to take the medication. However, what we find here is that we've not addressed the motivational premise that was mentioned earlier. So the patient's confidence for change is still low. What we know is that for a person to change behavior, not only does the patient have to find that that change is important to make, but that they have high enough confidence to make that change. So let's look at the motivational premise. Early on, we said that in the sense-making statement, that my life is hectic is the motivational premise. And the patient has then expanded on that by describing the work hours and the need to take care of the kids when he gets home as the motivational premise that still is in the way of taking the medication regularly. So what is important here is that unlike the factual premise, the patient is the expert in the motivational premise. So we really need to elicit from the patient ways that they can move forward rather than trying to provide it to the patient. Now we do that with using OARS, but we're going to be using it in a slightly different way, and we're also going to use rulers, which I'll get to, and we're trying to elicit what we call preparatory change talk. Preparatory change talk would be statements from the patient about their desire for change, their ability to make a change, reasons for making a change, and needs for making a change? What would they need to do that? So, for example, if we were to ask, what would you like about losing weight? The patient would say, well, I would like the fact that I would be able to move more easily, or I might have less knee pain. If we were to ask, how could you start to exercise? Then the patient might say, well, I could start by walking around the block. Reasons for change. And sometimes these reasons are the same reasons, same things that a patient described in desire, but that's okay. What are some reasons to lose weight? Well, I know that it's affecting my blood pressure, so it would help me with that. So you could see here that the responses that we are getting from the patients are actually what we call change talk. These are the more that a patient uh, can make statements of change talk, the more likely change is actually going to happen. The more the patient talks about why they can't do something, the more likely that the patient will be unable to do things. So that's why we are phrasing these questions about desire, ability, reasons, and need to get responses that represent preparatory change talk. So if we look back at our example, we can start off where we left off. Patient says, well, I want to take medication every day, but my job is unpredictable hours, and when I get home, my partner needs help with the kids. You're really busy and you're wondering how to fit it in. Yeah, I guess I need to figure out a good time. What are some things that you do consistently every day, regardless of your job or the kids? Well, I do brush my teeth every day. Could I take it then? You certainly can. How confident are you that you could do that every day? Oh, very confident. So a summary statement could be, you really want to do all you can to prevent a heart attack, which includes taking your medication every day. You had concerns about how to do this, but feel confident that taking it when you brush your teeth will work for you. Am I missing anything? So you could see here that my questions or statements, my reflections and open-ended questions back to him really reflect the patient's, I'm trying to get the patient's feeling of ability, need, and again, ability, and I'm trying to get the patient to provide that because that's going to result in more likely change. So summarized here, what I'm doing is I'm asking for open-ended elaboration about change talk. So how else could you do it? What else would work for you? I'm going to affirm any change talk with strength-based statements. So despite some barriers, you've made progress or you're making a strong effort to do things differently this time. I'm also going to reflect any change talk the patient gives me. You're really starting to see some downsides of keeping things the same, or you're really starting to see the upsides of making the change. And then I'm going to take a collection of any change talk that the patient has given me and then end it with an open-ended question. And you saw me doing that here at the bottom. So one additional very powerful tool for evoking change is the use of rulers. And that basically is listed here on a scale of 0 to 10, with 0 being not at all, and 10 being extremely confident. How confident are you about, for example, losing weight? Now, if the patient says a 5, what you don't want to say is, well, why isn't it a 10? What you actually want to do is to give a lower number. So if the patient says 5, you might say a 3. You say, why are you a 5 and not a 3? The answer you're going to get are the reasons why their confidence is higher, right? Which is, again, change talk. What help might you need to go from a 5 to a 7? So I am asking for a higher number here, but only because I'm asking for more change talk. What are they going to need to get there? And then we can ask, if they needed something, how could they get that? We are again asking for more preparatory change talk. If we can get the sense of importance and the sense of confidence to be higher, then we're going to have a more likely health behavior change. So finally, we get to planning. Once we've done the engaging, we've explored the sense making. We've focused and honed in on what the premises are to the current health behavior. We've worked with the patient on the factual premise. We've worked with them on the motivational premise. We've used OARS to now elicit preparatory change talk. What are we listening for that would allow us to know that the patient is ready for planning? So this is what we call the so-called a mobilizing change talk. And this is commitment, activation, or taking steps, or what we also call CATS. So if the patient has gone from, well, I'm thinking about doing something, to I will, for example, I will try to take the medication every day, or the patient says, I'm ready now to start to exercise, or I've started to walk once a week. Now the patient is gone from thinking about it to actually doing something. So this is a sure sign that the patient is ready for the planning process of MI. And even here, we want to make sure that we want to know their ideas for change, and not move too quickly and tell them what we think that they should do. Now, what about if a patient is not telling you, giving you commitment, activation, or taking step language? What if you're still hearing mostly what we call sustained talk, which is the status quo, or just lingering with preparatory change talk? Well, it's important not to jump ahead and go move into planning, and you actually want to stay in evoking. And sometimes patients will stay at this stage for multiple visits or many months or sometimes even years. And it's important to work with the patient and not get too far ahead of them before moving into the planning process. So if we are able to collaborate with the patient and get to the planning process, what is a very helpful tool to make sure that planning goes as well as possible? There is something called SMART goal setting, which has been very helpful. And this is essentially open-ended questions that really get to a specific goal, a measurable goal, attainable goal, a relevant goal, and a timely goal. So what is a specific goal? Well, it would be, for example, start walking rather than simply start exercise. What's measurable? 3 times a week is measurable, whereas only walking is really not very measurable, other than whether they're doing it or not. Attainable would be maybe starting off by walking around the block for someone who's been sedentary, versus running 10 miles, which may not be the particularly attainable or certainly not sustainable. And then finally, and then there's relevancy or relevant. So starting walking would be relevant to an exercise program, but eating less salt while healthy is really not relevant to an exercise program. And then finally, timely. Starting this week would be timely, versus starting next year, not as timely. So once you use these open-ended questions to get what the patient feels are SMART goals, then you want to follow up finally with a follow-up plan, an agreement to follow up and say a week, 2 weeks, 3 weeks, to see how that SMART goal is working out. If the SMART goal has not been working out, that's not a failure. That's simply more information to know what is a smarter goal. If they've met the SMART goal, then it's at that next follow-up visit, it's working on the next goal that, again, is still a SMART goal. So those are the 4 processes of MI. Here is a quick summary. We start with engaging, where we explore the patient's sense-making and we build rapport. We move on to focusing, where we assess the patient's sense-making, followed by evoking, where we address the sense-making, and for factual premises, we reframe. We use the provide ask tool. If it's a motivational premise, we use the darn questions and use rulers to use the ORS questions more effectively. And finally, if the patient is expressing CATS, then we know that the patient is ready for the planning stage. And when we do that, we elicit SMART goals from the patient. Hopefully, this has been a very useful introduction to MI. Of course, this is just the beginning. I encourage you to take a look at the two books that I mentioned at the beginning of the podcast. They could be both very helpful in practicing MI. I appreciate you for listening.